I think we are live. So just to start over again here, my name is Nick Place from Route 961 Training. With me, just as last time, Joe Kyle from Operation Rush. With spring right around the corner, we're just going to get right into it. This is a good time of year to get into drug physiology, and we apologize for the technical problems we had in the beginning. So I'll just go ahead and introduce Pharmacist Dan Walters, a guy that we go through to get answers from for physiology and drug actions in the body. Welcome, Dan.
Thanks, Nick. All right. So we're live, we're good to go?
I think so. Again,
Okay.
I apologize. I blame Joe. He had a little problem with the FBI and porn, and we're at his house today. So that's, I blame Joe.
Although we're on Nick's channel, so I'm not quite sure how that works.
Yeah. Yeah, so we spent, 20 minutes
Yes.
yucking it up, so we make up for lost time?
Yeah.
All
So
right.
it looks like my phone says we're live. So
All right, perfect.
again, apologize for the technical difficulties, but Joe's porn problem transcended into this webinar.
All right. So as I was saying earlier that none of you were able to hear, my name is Dan Walters. I'm a pharmacist. And Joe and I have known each other for probably 4 or 5 years now, Joe. Is that right?
Yeah.
And I've been practicing pharmacy since 1987, so about 30 years. And if I were to go back and kind of look at my career and say, what did I ever envision myself ever giving a talk like this, let alone sitting at a table with 2 police officers, I'd say there's no way this is going to ever happen. What are you talking about?
At least you're not under arrest.
That's a good thing, yes. So the first little slide I have up here, it's kind of funny. It's funny, but there's always an element of truth in some of these memes and things that you put out there. So from the most dangerous man in the world, I don't always try to refill my hydrocodone early, but when I do, it's because the pharmacy shorted me and I dropped the few that weren't stolen down the sink. And as I was on my way out of town for a funeral, and my doctor said it was okay. So as I was telling Joe earlier, in the good old days, hydrocodone you could refill. Now you can't, being reclassified several years ago as a controlled substance. We were also talking a little bit about the transitioning away from paper prescriptions to electronic prescriptions to try to get rid of some of the fraud, waste, and abuse. And we were also mentioning briefly that some of the healthcare plans now, mostly the Medicare plans, do require that prescriptions for controlled substances within the next several years be sent electronically. So we're trying to get away from the paper prescriptions, but they're still out there. Do you have anything else to add, Joe?
Well, I guess the question on the, is it just Schedule 2s that are being electronically formatted, sent to you? Are you still getting paper scripts, or is it going to be all 2, 3, 4s, and 5 eventually that will be electronically formatted?
Yeah, so we're seeing electronic scripts flow over for all classes, 2 through 5. We still get a number of controlled substance prescriptions, out of ERs, walk-ins, but the trend is going more electronic.
So because they're electronic now, do you have any issues with them, or is it like pretty much everything is the safest way to do it, or is there still issues that you found?
So the encryption process between the pharmacy and the provider, that link is pretty secure for the most part. The issue we run into more from a pharmacist standpoint is clarifying directions. A lot of times there's duplicate orders, there's dispense dates that sometimes get missed. There's notes and comments that get put at the bottom in very fine print that sometimes gets overlooked. So for instance, we had a prescription, two examples. One, we had an episode the other day with a patient that had surgery. Friend came in to pick up prescriptions. We had a prescription come in earlier for some Vicodin, and then shortly after, one for oxycodone 5 milligram.
For the same individual?
Same individual, same doctor. Called the hospital, spoke with the nurse. They said, "What's going on here? This makes no sense." About 5-10 minutes later, she comes back. We intended to discontinue the first prescription for hydrocodone. I said, well, that's nice because it's ready, and had he picked it up, we'd be having a different conversation. So the timing and not being able to get that information to us, saying, let's cancel this, that's a problem. So that communication is still an issue.
Is there a time that people have, and a lot of time, years ago it was like you had 7 days to pick up your script. If you didn't pick it up, the script would be invalid. I know that was many years ago. Is
Right.
it still like that now, or is it? I know it's also state by state.
Right.
Has differences. What do we hear in Wisconsin?
So state of Wisconsin, a couple things. So a controlled substance prescription is valid for 60 days from the date that it's issued. It used to be 90 days, and it was changed to 60 days back, I'm going to say in the late 90s, around 2000. As far as the time between order and pickup, so if something has been, let's say, order for a pain med and it's sitting in your pickup section for 7 to 10 days and the person comes in, then we start asking questions, like what's going on. And a lot of times it could just be, something was ordered, person got put in a nursing home, now they're being discharged. It could be something where many times, if that happens, we're going to make a call to the doctor and find out, like, okay, what's going on here. Commonly, what you see, the other thing that we see sometimes are the classic dental antibiotics and pain meds, where the person will come in and say, well, I don't want the antibiotic, I want the pain med. That kind of thing happens. So then a call to the dentist, and that gets a little dicey, because then you're looking at, okay, what's really going on. Obviously, dental pain, you want to treat it, but why is the person refusing the antibiotic? That's a red flag.
Sure.
So, but there's really no, it becomes a professional judgment kind of thing, working with the doctor, the patient, like what's going on here.
So are you able to, like, say it's been 15 days, are you able to refuse
Oh,
them?
absolutely, and we have done that. Yep.
Okay.
Yep. We've had prescriptions, for instance. I can tell you a quick story before we move on. We had a situation last summer. Regular customer of mine, he was in a minor fender bender. He went to the ER. Doctor prescribed him like 5 fentanyl patches. And I start talking to the gentleman, and I look at his profile on the computer. I don't see any narcotics. I don't see any previous history of opioids. And I say, what's going on here? And he says, I was in a little bit of a fender bender. And I said, well, you look, I don't know how much pain you're having. I said, but you don't look like you're in excruciating pain. I don't want to, say that you're not, but what's going on? He said, yeah, I went to the ER, got looked over. A little bit of back pain, a little bit of neck pain. I can sleep upright at night and get 5-7 hours of sleep. A little trouble getting up in the morning. Once I'm up and around, I'm doing okay. So I called the emergency room doctor and I said, what is going on here? I said, this guy is, he's up, he's walking around. Yeah, he's bruised and banged up a little bit. Why are we giving him fentanyl? What's going on here? And he's like, well, I got to treat the pain. He's in a car accident and I got to give him, narcotics for pain. And I said, well, not really, you don't. So we didn't fill it. And I said, here's what we're going to do. From talking to him, he's not had codeine, he's not had morphine, he's naive. What we saw, opioid naive, somebody whose body's not been exposed. I'm very leery of things like put on a fentanyl patch.
Right. Start off there
and the guy's walking around and he's got pain, but he's not at the point, he's not cancer pain, he's not post-surgical pain. So we didn't fill it, and I saw him actually just last week, and I brought it up to him. I said, remember last summer at this time? He's like, oh yeah. I said, yeah, good thing we never filled that prescription. He's fine.
Sure.
Okay, so that's another situation. But yeah, we still see issues with ER docs. They want to treat the pain, and I think sometimes they may overdo it. They don't check the PDMP necessarily before they send out orders. They don't call the pharmacy. We'll talk about that maybe if we get time later.
Okay.
And if people have questions, don't be afraid to put in the comments section your questions. We're monitoring that, and we'll do our best to answer those.
Yep. So we're gonna cruise right along. Initially, when I put this talk together a couple weeks ago, I wanted to just spend some time talking about the physiology of the autonomic nervous system. Joe has picked my brain over the year on the blood-brain barrier, and what's going on with that. We'll talk about that a little bit. I do want to just give you some basic terminology and then talk about some of the drugs. This is going to be kind of a sampling, if you will. If you're at a smorgasbord, we're going to just see a lot of different slides, different things that we can talk about. I want to keep it interesting because I know we got delayed, and I don't want to bore you. So my goal is to try to tell you a little bit of stories along the way and entertain you. But basically, it all starts with the autonomic nervous system. Would you guys agree with that?
Yeah.
When you guys are out there looking at people you're pulling over, you're looking at that what I call automatic nervous system, right? That sympathetic, parasympathetic, fight or flight versus being chill.
Correct.
Right? When those two systems are in balance, no problem. Somebody's on a stimulant, someone's on an opioid, someone's on alcohol, that whole system starts to get out of balance. That's where your expertise comes in. You match the drug with the patient, you make a case, right? That's how it works, pretty much?
Pretty much, yes.
But it's not straightforward. And we
No,
talked about that
especially when you
before we
start
went
mix-
on.
Yeah, when you mix multiple drugs together.
Yeah.
It's
So we talked, I remember one time we first started talking about this, you texted me or called me and you said, dude, I pulled this guy over the other night and his pupils are doing 2 or 3 different things and I'm looking at the drugs and it doesn't add up. What's going on? Well, at the time I didn't know really how to respond. I didn't know, but I said, it's time for me to go back and look at the drugs, look at the physiology, look at the the biochemistry, and try to come up with an explanation. So what I found over the years is that one thing that I'll just say out there that you guys and gals probably know this, but I'll just make it known. Whenever you have somebody obviously who's been on drugs of abuse, they've got a habit, they're addicted, their body over time has changed, right? They're not the same person physiologically. So when you try to assess that person, it's not like you're assessing your teenage son or your grandmother. I mean, it's a different dynamic you're dealing with, right? These drugs are affecting systems in the body, so it's not straightforward, right? So we can look at this here, and on the left-hand side, the sympathetic response, classic example, you pull someone over, you're in a high-speed chase, your heart's pumping, your blood pressure's up. You're not worried about the right side. You're not worried about, going to the bathroom. You're not worried about if your food's going to be digested. You're working on the muscles, and that blood flow is going to where it needs to go. After it's over with and you calm down and you get back to normal, then that right-hand side, that parasympathetic system kicks in, right? Resting heart rate's good, the blood pressure, everything's back to normal. So when you deal with drugs of abuse and you look at somebody's pupils, you look at, and we were talking about this earlier, you look at somebody, for instance, who, abuses promethazine with codeine, for instance, and Joe and I were talking about this when there was a technical glitch, but basically somebody who's on the promethazine with codeine, they're going to be constipated. Why? It's basically slowing down the gut, okay? Get a female patient who's a long-term abuser, let's say, of promethazine with codeine, you arrest her, you throw her into jail, she gets a UTI, say 3 to 5 days later. Why? Well, the bladder, because of the promethazine, it's slowing the bladder muscle down. So urine backs up, UTI develops, that's how that all works. So not to mention the whole teeth. We didn't talk about oral health, right? So someone who's an opioid or drug abuser, the last thing they're worried about is, flossing their teeth and using their water pick, right? They don't care. So we do see a lot of dental problems, right?
So the immune system is also one of the systems that's compromised a lot from
Yes.
some substance abuse.
Right. Yeah, that immune system, meth users, even people on opioids, right? There are opioid receptors, right? So the targets of where codeine, morphine, all those, fentanyl, there are receptors on T cells, B cells, your immune system, right? So there is that interplay with drugs in your immune system. You're absolutely right. We're going to talk about the blood-brain barrier. This is always challenging because I never know which slide to use to show it. But essentially what happens, if you think of the brain, there's and it's not just one layer, but this shows it kind of, I think, makes it easier to understand. Your brain has a layer to protect it, okay? So if you take away the message, why does it have a layer? Well, it's trying to keep stuff out, right? We don't want stuff getting into our brains. We don't want bacteria. We don't want viruses. Funny. There's you ever see these neti pots, these sinus rinse pots that people use? I use them. I think you and I talked about. You use them. There was a report not too long ago of a lady who was using tap water rather than distilled water, and in the water was an amoeba. It was contaminated. Guess what happened? Guess where the amoeba got in her brain? She ended up in the hospital. Yeah, sure. She got amoebiasis, or an amoeba infection of her meninges in her brain. Okay, so even though that barrier's there, it can be penetrated. Think of a castle with a moat. There's always a weak link. Sure. And if you're a villain in the medieval France and you're trying to take down the king, you're going to find a way to get past that barrier. There's always a weak link, right? There's also drugs, because of the size, the chemistry, how it's delivered, that can easily penetrate that, right? What was that movie about the Pittsburgh Steelers guy, the Mike Webster? You ever see that movie? I forget. It was based on the guy who did the concussion studies with the NFL.
Yeah. Okay, yes.
I forget the name of it. It was
right.
Will Smith or somebody who played the doctor.
Yeah.
You see the guy out in the parking lot with the butane and huffing, right? The guy had so many concussions, so much pain, and he's huffing and taking in lighter fluid and whatever. Those are gases, right? Anesthesia gets past that barrier, right? It's in a form, it's a gas, it penetrates, gets in the bloodstream, crosses easily. So
fentanyl is like one of the best drugs to get through that. I read a book on drug interactions. Fentanyl and heroin are two of the best drugs to pass through that. Fentanyl is even good enough it can get transdermal and get in your skin.
Right. In law enforcement, you guys have to be careful because of those at the carfentanil, right? That comes in contact with, you've got latex on?
Yeah,
right?
Yeah, well, you should have gloves or even treat it like a bomb, and sometimes even just stay away from it if it's in dealer amounts.
Right, and now you're I'm assuming you guys got Narcan readily available?
Yes.
Yeah. not so much for the people that you pull over, but for yourself, right? Self-protection.
Right.
So that, the world's changed, right?
Yeah.
So yeah, that blood-brain barrier, basically where that came from, if you go back and look at the science, it was actually done in a lab and with rats. Take a blue dye, you inject blue dye into the abdomen, sacrifice the rat, you find the blue dye everywhere except the brain. Now you take the brain, you inject the blue dye into the brain, and you find it in the brain but nowhere else. So there's a barrier there that's keeping
Okay.
it out. Does that make sense?
Yeah.
Sure.
So it's keeping it out. Long-term drug abusers are breaking that barrier down, right? So like with heroin, heroin, like you said, very potent, getting right beneath that barrier, that's where those little gaps in the moat are, where it can find its way in, transport systems. It gets in there very rapidly, gets converted to morphine, and then the morphine causes the big dump, right?
So the more you use, does the barrier actually continue to break down over
Yeah,
time?
yeah. So you look at somebody who does like crystal meth and that kind of stuff, you look at brain images, you can see the decay
Okay.
that going on.
Really?
Yeah, you can see some pretty cool, if you Google images on like Amen clinics, or you look at any brain imaging studies of like long-term meth users, and then you look at what happens after they stop, and you see part of the brain actually can recover, which is amazing. Not always 100%, but the body's innate ability to recover, even brain cells have the ability, depending upon the location and the damage.
Sure.
So it's possible. But yeah, Breaking Bad, classic example, right? Whenever you read about crystal meth or you talk about methamphetamine, yeah, look at this as that barrier breaking down. It's just getting pounded repeatedly, and it gets weakened, right? So that's essentially an easy way to explain it. So we talk about principles of drug action. Essentially, keep in mind that the skin, I put skin up there off to the in the parentheses. We talk about absorption, distribution, metabolism, excretion, right? And they're all different. Everybody, older people are going to break down things differently. Keep in mind the skin being the largest organ of the body, right? Large surface area, a lot of blood flow, great target for drugs. We talked about fentanyl. Fentanyl is a great drug when it's used properly. When you need it for like, let's say, cancer pain, or intravenously like post-operative pain, pre-operative pain. My wife had her appendix removed several years ago, and my wife's got a long history of health problems. And so when I talked to the surgeon, who's a friend of mine, I said, Bill, we need to talk before you put my wife under. She's complicated, let me tell you. So we spent a half hour going over her history, which I greatly appreciated. I said, what antibiotics, what kind of pain meds you're going to put her on? They put her on a very low dose fentanyl, extremely useful for pain control. Good friend of mine who's a nurse anesthetist, like fentanyl is one of the best drugs ever, but it's got a bad rep.
Sure.
Because it's being misused. Now it's being spiked in, medical marijuana. It's showing up in, who knows where it's going to show up, right? Because it's coming in from China, Mexico, wherever.
Right.
So fentanyl's a great drug when properly used. We got a slide coming up in a second. Keep in mind that the principles of drug action, we talk about pharmacodynamics, what the drug does to the body. We talk about kinetics. This is the kinetic. This is where all the action's at, what the body's doing to the drug, right? So you got somebody who's got a stomach problem, you're not producing stomach acid, they're not absorbing stuff, their intestines are a mess, their liver, maybe they've got cirrhosis, they're a smoker, maybe they got diabetes. A lot of people with diabetes, their kidney function's declining. So you pull somebody over and they're abusing drugs. Well, if they got diabetes, guess what? Their body's not functioning properly. So they're going to be more susceptible maybe to lower doses. Does that make sense?
Mm-hmm.
Potentially, right? So not all physiology is the same. You got to look at the person, look at their underlying condition, look at their diseases. You got to treat each person on its own merit. So pharmacodynamics, okay, drug, dynamic action, what the drug's doing to the body, okay? We'll talk about drugs and receptors. We got a few slides coming up that will just explain that very briefly. Kinetics, we just talked about, that's what the body's doing to the drug. People who smoke, for instance, are going to metabolize drugs a lot faster. Alcohol is a very potent enzyme inducer, okay? So long-term alcoholics, they'll metabolize drugs much differently than somebody who has not drank, who's got a healthy liver.
Because of liver problems. So
Yeah.
diseases or something that affects the liver
Yep.
is going to slow down the metabolization of whatever drugs you take later on.
So alcohol actually induces enzymes in the liver, which can speed up elimination. And of course, one of the myths, of course, with people who drink alcohol is what do they try to do to counteract the effect? Caffeine, right? And we know that doesn't work
Right.
because the kinetics are different. There's no cure for someone who's intoxicated with alcohol other than support and let the body eventually, because zero order, right? It takes a longer time to eliminate. You can't speed up the elimination with charcoal. You can't inject and give them a shot of anything. So the kinetics of alcohol are completely different than most other drugs. Okay, so that's interesting. And I know a lot of you guys know more about alcohol than I do, but it's interesting that alcohol is legal. It's been around for it's part of our society, right? In Wisconsin, when you turn on the news in the morning and there's an accident or there's some shooting, what do they always say? Alcohol may have been a contributing factor, right? Alcohol is part of the culture. It triggers lots of problems. We're talking about potency and efficacy, and I've got a nice little graph. If you ever hear somebody, ask a pharmacist, and what really drives me nuts is when somebody say, "Is that a strong drug?" I hate that because there is no such thing as a strong drug. It's either a potent drug or it's an efficacious drug. It's not strong or weak. It's either potent or it's not. It's either effective or it's not. So, but that's more of a marketing thing. But it still drives the hell out of me because in a purist standpoint, we're talking potency and efficacy. And the graph will show that in just a second. So just remember, dynamics, drug, acting on the body, kinetics, the body's acting on the drug. That's all you got to know. Okay, so dose response curve. This is where it gets interesting, but essentially what we're looking at, you can measure any response you want on the vertical axis, going up and down, and then the dose of the drug going left and right. Essentially what we're looking at are two drugs. You could pick any response you want, whether it's a cholesterol drug, and we're looking to see, how much is drug A going to lower cholesterol, how much, drug B going to lower cholesterol, stomach acid, pain relief, it doesn't matter. So drug A and drug B produce a response, and they produce an S-shaped curve, which is kind of interesting because whenever you see a dose response curve, you ever look at drugs and how they work, whenever you see this S-shaped curve, that's indicative that the drug is probably working through a definitive system. There's probably a receptor that's known, so now we have a mechanism of action that we can attribute it to. So whenever you see an S-shaped curve, there's a drug and there's a receptor, okay? And the response that we're looking at, or the activity, is the efficacy, okay? So drug A and B are both effective, but B is more effective, right? Because if you push the dose for drug A out far enough, you only get the max response. So you can push the drug dose as far as you want to the right. Drug A doesn't matter. It's not going any higher, and it may contribute to side effects. Drug B, same thing. You push the drug farther out, it'll have a plateau. Okay? So one thing I didn't do that I should have done, I should have taken drug A and drug B, and I should have moved them closer so that drug A and drug B kind of cross over. What you'll find out is that methadone and buprenorphine, which are two drugs that you guys are familiar with, if you have somebody who's in pain, it takes a while for methadone to kick in and work. Because methadone has a long half-life. It has to kind of build up. It has to kind of kick in. So if you give somebody Suboxone or somebody who's abusing buprenorphine, I never forget I had an officer up in Marinette when we gave that talk in Wausau a couple summers ago, came up to me during an intermission. He's like, what's going on with buprenorphine? I'm seeing these guys load up on high-dose buprenorphine, and they're getting like huge responses. Now, I look at this graph and I say, well, it should plateau much lower than say like methadone. Well, what was happening was blood-brain barrier, dose response. You push it far enough, you can get those kinetics, right? You push it fast enough and high enough, and you can get a different response. So it gets kind of blurry, but at low doses, if you compare like buprenorphine with methadone, the buprenorphine will produce a quicker response. We'll talk about why that is. But after a while, the methadone, because it's going to build up, you're going to get a steady state level, that's going to be a much more effective drug for a severe pain condition. So somebody who's got chronic pain, and I'm not a big fan of methadone, and methadone is kind of fortunately being phased out from the pain clinics, thank God. We have a couple people on it, but the trend is to get people off of that, because in combination with benzos and soma and these muscle relaxants, it's a deadly cocktail. And unfortunately, we've seen that in this area up until recently with some of the issues that have been kind of in the news. So potency and efficacy, and Nick and I were looking at this earlier. We were kind of going over this, kind of explaining this to him, and he got it right away. Basically, morphine in the middle. Whenever you talk about opioids, morphine is always the reference standard, right? It's what we call all drugs in relation to morphine. So when we talk about morphine milligram equivalents, and in particular with the opioid crisis, one of the things that happens is you're looking at how many milligrams of oxycodone do I need to get a equivalent morphine dose? And so for instance, I can never remember these, but a couple principles is that morphine and hydrocodone are almost 1-to-1. So if you got somebody who's taking 50 milligrams, say like 10 Norco 5-325 a day, 50 milligrams of hydrocodone, they got 50 milligrams of morphine equivalent in their body, okay? Fentanyl's a little bit different because for fentanyl, if you put somebody on 20 micrograms of fentanyl, for instance, you get about 50, so about 2.5 times the equivalent. And so when you look at the dose to the left with fentanyl, it's more potent, right? We need less drug to produce the effect. You need a little bit more morphine, but they both give you the same efficacy, right? Because they both plateau out. So you can get the same effect with the two drugs, but you need less of one than the other. We'll talk about why that is. And then we could compare aspirin, because aspirin is, in comparison, is pretty weak, right? So that should make some sense. So think of, if the curve shifts to the left, it's more potent. It may be less effective. It may be the same efficacy. It probably won't be more effective, but it'll be the same or less. That's how you can kind of think of it. So basically, when you talk about drugs and how they produce their effect, you're talking about pharmacodynamics, what we talked about, what the drug's doing to the body. Down on the left, it's a classic lock and key. To the right, it's more science, more chemistry. Essentially, drug companies, when they design drugs, and when people who operate in the netherworld who design synthetic drugs, they look at the little picture to the right. Okay, so the chemists and the people who understand chemistry and stereochemistry, which is like 3D, they know how to change the structure of THC to K2 to get that lock to stick in the key longer, right? And we talked about a colleague of ours earlier that we all know, who really understands THC and understands the drug receptor stuff. And a part of that's because he and I over the years have, we've talked a lot about that. We've spent some time discussing some of the science, but just think of it as a lock and key, okay? Think of sticky keys producing stronger, more dynamic interactions, and those loose keys in and out, not as potent. So buprenorphine, in and out, fentanyl sticks, won't come out, right?
Okay.
Produces that response. That's efficacy too. So the longer it sticks to the receptor, and the longer it's stuck, the greater the response. And this slide here, the next one, under lock and key, basically the top one just shows your body releases hormones and neurotransmitters, right? So norepinephrine, adrenaline, testosterone. We have endogenous receptors in our body that do basic physiological responses. We also call drugs agonists, okay? That's the term we typically use. So drugs that are gonna bind to a receptor, or that key that's gonna go in the lock, it's an agonist. It turns it on. Now the key can be sticky or it can be loose. Okay, think of it as somebody coming up here who's got a really strong handshake, hasn't seen you in a long time, doesn't want to let go. That's a strong agonist. That's a drug binding to that receptor. Won't let go. It's going to produce that effect longer. Someone that has like a handshake of a wet fish, it slips right out in and out. It's not as strong. Okay, and then an antagonist. Classic example that we talked about earlier is Narcan. Right, Narcan will reverse that opioid response. It'll get on there, block that receptor, pop it off. You got somebody who's not breathing. You Narcan them, they're going to come back pretty quick. We hope. So agonist, antagonist. Depends who we're talking about, Joe. Is that what you're trying to say? I can't see that body language. It's pretty funny. Okay, so for selected drugs, I just put a couple up here. So OxyContin, I'm gonna have a couple quotes. Maybe some of you have seen this that are coming up. We talked about fentanyl quite a bit. Great drug when used properly. Bad drug when not used properly. When it's overused, when you use the black market, you see it. We talked about earlier. You're finding it in medical marijuana. You're finding it all over the place. It's a danger to law enforcement, obviously, with the carfentanil, which is a synthetic form. It's been modified, right? That's where that stereochemistry comes in.
Very sticky key for carfentanil.
Yeah, very sticky, right? Yeah, you don't need much, and you're in trouble. Nucynta, tapentadol. It's a tramadol derivative. Talk about tramadol a little bit too, because that's kind of interesting. Tramadol is becoming the go-to drug, it seems like, for pain clinics, for primary care. It's used, it's not supposed to be used in children, I believe, or teens under the age of 17. But I've seen it used in 14, 15-year-olds, and it scares the hell out of me. I've seen it used in older people. Max dose is 50 milligram tablets. The max dose is 400 milligrams. 400 milligrams of tramadol. If I have my slide here, so 400 milligrams of tramadol is equal to 40 milligrams of morphine. Okay, so each tablet, 5 milligrams. morphine per tablet. So there you go. So you pull somebody who's got tramadol, each tablet you're looking at about 5 milligrams of morphine equivalent.
Okay. Is there a reason why doctors are switching to tramadol? You mean
Yeah.
or is there perception, or what's your take on
Yeah,
that?
I think it's perception. I think oxycodone and OxyContin, because of all, when you say oxy, everybody knows what oxy is, right? It's killing people, it's overprescribed, it's corporate greed and corruption, which I got a slide on. So let's go with something that would treat pain, but it's less of a problem. And I think people gravitate to tramadol. Problem with tramadol, and I didn't talk about this in the slide, so Nucynta, which is a C2, tramadol is a C4, okay? So they both have almost the same pharmacology. They both bind to opioid receptors. They both block norepinephrine reuptake. Tramadol blocks the reuptake of serotonin 3 times as much as Nucynta. So why is that important? Okay, so one of the problems is you have drugs on the market that are serotonin reuptake inhibitors, drugs like Prozac, Celexa, antidepressants, widely prescribed, SSRIs, which I'm sure you guys have heard of.
Yep.
Okay, those drugs block the reuptake of serotonin. Now you throw in a narcotic, and that bumps it up even more. So there's a condition called serotonin syndrome, which is not, I mean, it's well known in the literature. It's not sure, and I've seen it a couple times. I've seen it mostly in younger women, but essentially what happens is they start to get severe confusion, brain fog, flaccid muscles, high temperature, core body temperature. In Wisconsin, apparently the genetics, if you believe the genetics and the lineage, there are folks who, of Eastern European, German, Scandinavians, in the female portion, certain generations have a higher tendency for that, for producing serotonin syndrome, so much so that some of the ERs used to have what's called a malignant hyperthermia protocol, which essentially if you get somebody who comes in and their serotonin levels go up too much because they have the genetics or the proclivity to have a crisis, they would screen for that upon pre-surgery, and then they would have a plan in case during surgery they would start to develop the symptoms. So that was 20 years ago. I don't know how common it is now.
Sure.
I've always seen it a couple times. And so, yeah, that's another concern. Tramadol, as we talked about earlier, it is the stigma, I think, that's happening, because we do see a lot of tramadol coming out of family care, our family practice, internal medicine, pain clinics. Pain clinics are trying to get away from the oxys. They're trying to go more intervention-based with the more manipulations, the injections, the burning of nerves, all sorts of funky stuff to treat pain.
So there was a new one that I heard that the FDA approved was sufentanil or something to that effect.
Yeah, the little rice size of a rice bead
Yeah.
that they use for surgery. It's supposed to be used for surgery only.
Only surgery.
Yeah,
Okay. 'Cause
yeah.
I was curious as to why we needed to. We already have one that's.
Yeah,
so potent,
sufentanil,
why
we don't
would
need
we
another
need-
one. Yeah, that's the outcry. We don't need another one. But because it can be made and approved. And drug companies have lots of money, and they know politicians, and they've been at the FDA, and they can get their drugs approved. Right? We have the best government money combined, we have the best corruption. It's true. And you don't believe me? I'll show you. That's a good segue. So, big pharma and corruption, right? So there's going to be people, if this video gets out to the drug companies, my body's going to show up in a lake. So you guys know where to look for me. They don't like hearing this stuff, but it's true. They don't like hearing from a pharmacist, but I'm sorry. I don't agree with a lot of my pharmacy brethren. I question a lot of stuff, and I piss a lot of people off. You don't believe me? Ask my wife. Because I do, and I get called out on it, but you know what? I stick to my principles, and I'm sorry, but I'm not making this up, okay?
Well, I like what you've said in the past, is that there's a time and a place for a medication,
Yeah.
but it's not always.
No, it's not always. Like, I hate drugs because I don't like the way they're used. They're misused. There's good time to have them. So these are just some headlines. So OxyContin maker Purdue Pharma explores bankruptcy. Okay, that's a headline. That's not my words. Purdue Pharma's CEO says company considering bankruptcy. Those aren't my words. Oklahoma, one of the first states to sue for $279 million. Other states expected to follow. These are not my quotes. These are public record. You can Google them and look them up.
Even here in Manitowoc County, the theory was Bob Zigawar, our county exec, was going to go after Holy Family for all the damage that Dr. Siddick did to the community, all the kids that we had to put up, the fallout from that. And
Dr. Simon.
Dr. Simon. Yeah,
Yeah.
Dr. Simon, wrong name, but the
Yeah.
fallout that we had from.
Yeah, that was messy. Yeah, it was a mess. And then this is a quote from the the main medical director and I think it was the CEO at one time of Purdue Pharma, which made OxyContin. The first quote, he's on record. You won't believe how committed I am to make OxyContin a huge success. It's almost that I dedicated my life to it. After the initial launch phase, I will have to catch up with my private life again. So make the money now so I can relax later. Make your fortune now. Drug abuse. Now this is a classic. Okay, so this was the quote that people picked up on. It was on YouTube. It's on 60 Minutes. Drug abuse is not a problem in patients with pain for whom the opioid is appropriately indicated. Okay, so people for years thought that the pathways that led to drug addiction were not really a problem in people with chronic pain. If you got chronic pain, those pathways activate one way, and if you don't, you're not going to get addicted. That was taught in pharmacy schools in the 90s. Okay, I graduated in the 80s. That's bullshit. Okay, it is, because you don't know the makeup of the personality. You don't know. And we didn't talk about the brain, and we could get into marijuana, whether it's a gateway drug, whether it's not. But here's the thing. Parts of the brain develop differently at different rates. One of the problems, and I'll just talk about marijuana for a second, whether it's a gateway drug or not. I don't think it necessarily is or isn't, but I think it could be based on the individual, because here's what happens. In a teenager, that reward pathway develops much more sooner than the prefrontal cortex does, the brakes that tell the person to shut it down. So in a person who starts experimenting with marijuana early on, they like the effect, they get used to it, they're now 15, 16, 17, and you guys probably see this all the time. If you get somebody whose brain is such that prefrontal cortex can't tell them, shut it down, don't use it all the time, they become dependent upon it, they move on to something else, right? Not everybody,
Right.
but so marijuana, in my opinion, from what I've read and seen, is it a gateway drug? Maybe. In some cases, maybe it's not, right? You can't paint it with a broad brush.
I think that comes down to the thing we always say is, drugs are person specific.
You got it. Yeah.
And we don't know how a specific drug or medication will affect you.
Right.
We have a general idea.
Yes.
But it's still a human being. It's still a lot of
Correct.
variables.
Yes, and that's good. That's a good point, because that's the whole point of the talk, is that you have to look at each case on its own merit, right? Its own situation, because not everybody's the same. Everybody's body's different. So we talked about as far as ways to curb opioid prescribing. There's government regulations. The Trump administration has cracked down. They've put legislations and proposals that have started to become enacted. First of the year, we had people coming in who were getting Percocet, Tramadol. Well, guess what? Part D's, the older people, the Medicare prescription plans, those plans were impacted probably more so that I saw first of the year, because the laws started kicking in. So you needed a prior authorization. You can only get 7 days until there's clinical documentation. Guess what? Some people were switched, some people were taken off, or what happens? You get 7 tablets, you come back in a week, get 7 more, right? You just get it refilled. So does it solve the problem? It depends. It puts more of the burden on the physician to reevaluate and say, do I really want to keep this person on it? Do I try something else? And then you have the people who, I'll just pay cash for it, which you can do, but you got to document, like, why are you still getting this? That's another gray area. So non-drug-based options are becoming more of an option for some of the pain clinics, or switch to a different agent. We talked about Tramadol. Like, Tramadol doesn't have that stigma, at least not yet. But Tramadol, if I mentioned this, I can't remember if it was before we were having technical difficulties or not. Tramadol in Ireland is the #1 opioid for overdoses. Okay, so it's not benign, and it's not safer necessarily. So as far as current trends, this is what I want to tell you, kind of what I see from my angle. The whole purple drink. So in my pharmacy, what I tell my pharmacists and my staff is, if you see a script for promethazine with codeine, you need to treat it differently. You don't need to profile the person, but you need to think it may be a forgery. If you don't know the doctor, the person's not from the area, and this has happened a couple times. We've had doctors who have ordered like pint bottles, and the person's like in Milwaukee, or we had fake scripts coming out of Aurora from like Kenosha, that area, and people in the southern Milwaukee area may see this. Apparently there's a lot of technology where people are able to go on now and recreate prescription blanks. They're able to get the doctor's signature, able to imprint it somehow.
Now, are you getting those are just hard copy? They're not actually.
They're hard copies coming in.
Not the ones that are sent to you via.
Electronically?
Electronically?
No, these are paper scripts
Okay.
that have been doctored. Emergency room doctors and single entity oxycodone, still see that. Still see ER doctors order 5, 10, 15, 20 tablets, for pain. Not checking the PDMP or not calling the pharmacy prior to ordering stuff. A patient, month or so ago, guy's on high dose, long acting, abuse deterrent form of oxycodone. Doctor prescribes Vicodin. Why? Well, he went in and he asked the patient, what are you taking? He told him, I'm on this drug, but not the narcotic. The drug he told him he was on, but he was also on other stuff. So we didn't fill it. We called his regular doctor, and now he's got some explaining to do. Because they have a contract, you go outside network, you need a pain pill. No, you got to call us first, and we got to coordinate that. You call the ER doctor and say, you're aware he's on this long-acting form. No, he never told us that. Well, you think he's going to tell you that if he's looking for something?
That's
No.
right, look at this.
Why don't you call us? We
PDMP.
could have told you this. If you're going to prescribe a narcotic like that, I think in general, it makes sense. Have the nurse call the pharmacy. Like, okay, what's going on? It's a safety check, right? So taking the patient at their word is still an issue. We talked about the benzos and the muscle relaxants, still a problem cocktail. Lyrica, gabapentin. I imagine at some point gabapentin will be a controlled substance in Wisconsin. I think Kentucky it already is.
We're seeing a lot of gabapentin, especially with the opiate users,
Yep.
using with either as a substitute or in combination with their opiate medication. You've seen a lot of that come through on your end?
We got a few people that, we got to watch them because they weren't filled early or, they different things. So gabapentin, from what I understand, if you grind up the tablet or you get it through the nasal route, can produce, a high similar to like heroin. Is that what you're saying? What do you
Yeah,
see in the field?
they're taking a lot with their other opiate medications, or they're taking it as substitutes to get the same depressant effects that they would get with their opiate meds.
Okay, yeah, and gabapentin is one of those drugs that works differently than a true narcotic. It's not really a narcotic, it's more of
Right, it's more of a depressant, like a
Yes.
central nervous system depressant
correct.
for nerve issues.
You got
Usually
it.
What we see people get it prescribed for.
The thing that I don't like is all the people who come in and, the doctor will prescribe it for fibromyalgia. I understand the fibromyalgia, issue, but, and when we talk about fibromyalgia, everyone's strong opinions about that, but, yeah, we see that typically used for a lot of that. And I put tramadol as a new candy question mark because of what we just talked about. It seems to be, prescribed more than others. Just a couple things to wrap up. We talked about, briefly the farm bill that President Trump passed. Now you can, it makes, hemp and CBD up to about 0.3% is now legal in all 50 states, from my understanding. Is that your understanding from a law enforcement perspective?
Yeah, when hemp, when Trump passed that, the hemp is not, I think, based on dry weight.
Okay.
Not supposed to have a THC content greater than 0.03%.
Yep.
But there's no regulation, so
Right.
I could sell something that has 3%, and really, it's a tough time knowing what's in that product without getting it tested.
Right, and we talked about the potential for contamination, for tampering, for spiking with, who knows what. And you said
Synthetic cannabis.
and you said you came across something that had no CBD in it at all. It's being sold as CBD, right?
Well, yeah, it was sold as a cannabis oil, and we tested it and didn't test positive
Right,
at all.
right. So buyer beware, right?
Right, exactly.
Yeah, and we talked a little bit about marijuana as a gateway drug, whether it is or not. We're not gonna know, but it comes up in that whole context. As far as over-the-counter drugs, briefly, you guys I'm sure you're familiar with the whole dextromethorphan. We talked about stories here in town and some of the stuff that we've had to deal with. The Coracidin HBP, because it's got the dextromethorphan as well as the chlorpheniramine component, which is the antihistamine. That's becoming something that's more of a drug of abuse. Imodium, go ahead.
I was going to ask you. It's been a while since I've been to the Walgreens pharmacy, but are you keeping these medications behind the counter? I noticed at Walmart you don't really see these out anymore. Is that becoming a trend?
The Coracidin HBP we do keep behind the counter. There was a time where the dextromethorphan, there was some talk that it might be restricted to pharmacy only, keeping it kind of behind the counter. It hasn't, surprisingly. I thought that was going to be the next thing that was going to happen. So yeah, we do keep the Coracidin back there. Most people that come in that buy it, we have a problem with. but every so often, if you have a younger person come in that they don't have signs and symptoms of a cold, and really, kind of question what's going on.
Sure.
The Imodium loperamide, that's a classic drug for diarrhea.
Right,
That guys are using to offset the opioid shortage when
Right.
they get taken off opioids.
What kind of dose, because I get asked this quite
Yep.
a bit, like what kind of dose comparable, I guess, with your charts
Yeah.
to morphine, what are you
Yeah,
looking at?
so loperamide won't show up on that morphine milligram equivalent chart because loperamide basically is a derivative of Demerol, meperidine. So normal use is 16 milligrams a day for diarrhea. It's a max dose. There was an article, and I haven't been in my Costco lately, but a few years ago there was an article about how loperamide was being sold in bulk, and a lot of people were going to Costco to buy it because they could, take handfuls of the stuff, and they were, several hundred milligrams a day. Because if you push the dose high enough, what happens? It gets past the blood-brain barrier, and it hits the same receptors as the opioid, so they could,
It's
can't get my Vicodin, can't get my oxycodone,
Sure.
I go to Costco or wherever, get my, Imodium. I have not seen empty Imodium boxes in the store. I haven't seen that kind of stuff. But it definitely was a problem when people started getting, taken off or reducing access to that. So if you push it high enough, and then Sudafed, of course, with the, methamphetamine, Dramamine, not Dramamine, but Dramamine, it's a typo, and Benadryl, both the antihistamines, both can produce that, antihistaminic effect, that sedation, the fog, ephedrine, which you find in, you can get it in drug Primatene, Broncaid, that kind of stuff with the stimulants. Typically, from what I've read and seen, it's termed a sex enhancer. See teenagers using it. Now we talked about nutmeg paste a little bit. I was researching that, where that's becoming, I guess, the latest craze, or it's been around a while. I don't deal with this, but I just found it interesting that nutmeg paste produced this kind of effect. So
Yeah, Arrowwood has a whole thing on nutmeg and a lot of the other natural hallucinogens that are out there.
yeah, so a lot of stuff out there. A lot of people, I guess, who are inquisitive. I know we got a little bit behind. I know we're going to wrap it up. So Nick, you can take over.
Yeah, again, thanks, Dan, for taking time out of your day to go over this. Again, I think this is a pretty good topic to go over, and physiology is one of those topics that I think all DREs should know a little bit more about. Just to put some things out there, my 420 classes are filling up. My class next week, Friday, in Waukesha is full, but I do have another one coming up June 12th. And also on June, I think it's going to be June 3rd, Friday, June 3rd, in the Milwaukee area. If you are law enforcement or part of social workers, the community advocates, they're going to be hosting a 420 class there. Actually, I had the date wrong, June 7th. So you can reach out to me at dre11379@gmail.com, or look up my website, route961training.com, and learn more about that. And Joe, your conference not that far away as well.
Yeah, September 17th, 18th, and 19th. So registration is still open. Early bird special goes on till May 31st. June 1st starts the other venue, or not venue, but a larger fee. I guess it's $295 after the June 1st, $250 before June 1st. So a lot of great speakers coming in. Nick is actually one of the speakers this year, and ABCs of THC. We've got guys coming in from all over the country, so hopefully you can check it out. Go to www.operationrush.com, click on conference, and you can see the list of presenters that will be there.
Cool. Well, folks, thanks for checking in. We will save this to my YouTube channel, so if you couldn't, or people that weren't able to make it, if you pass the word along, this will be saved on there. And I will monitor the comments and questions and get back to people with any questions that you would have after the presentation is done. So for Dan and Joe, this is Nick Place signing off. Thanks for watching.